Good morning, good afternoon, and good evening, everyone. My name is Bidata Khatri. Welcome to the FIP series, FIP program, Shaping the Future of Self-Care Through Pharmacy. And this webinar is about health and self-care literacy for the management of minor ailments in the pharmacy, sore throat, cough, cold, and flu management. And I'll be the moderator for today along with Jaime Acosta. My name is Bidata Khatri. I'm a pharmacist based in India. I work as Senior Drug Safety Associate at a CRO in India. And with FIP, I'm the Secretary of FIP Health and Medicines Information Section. And I'm also a member of Indian Pharmaceutical Association. And my other moderator for today's session is Jaime Acosta. He is a practicing pharmacist and pharmacy owner in Madrid, Spain. He is the CPS Professional Secretary and the FIP Technology Advisory Group Co-Chair. And some of the announcements for today's webinar. The webinar is being recorded and live streamed via YouTube. The recording will be available on our website, events.fip.org, and you may ask questions using the question box provided. You are welcome to provide feedback to webinars@fip.org, and you can become a member of FIP at the website of the FIP. And some of the acknowledgements. This webinar is sponsored through unconditional funding by Rekit.
Hello, everyone.
So the rest of this, thank you.
It is, thank you, Vidata. It is my pleasure to welcome you to this webinar, which is part of the FIP series called Shaping the Future of Self-Care Through Pharmacy. Empowering patient self-care improves health outcomes and reduces the burden of diseases, and improving health and self-care literacy is therefore key to empowering pharmacy-based self-care, which is very important. This is especially important when it comes to the management of minor ailments through pharmacy. We received the news today of the English government funding with more than 700 million Great British pounds more comprehensive minor ailment service in England. So this is very recent news from this morning here in Europe. Going back to the webinars, consisting of a series of 5 events focusing on common health issues, this FIP digital program aims to examine how pharmacists can be enabled to improve health and self-care literacy. Approaches for 5 different areas of minor ailments are discussed, including embedding health and self-care literacy into education and training, developing self-diagnosis and self-medication protocols, widening access to patient information, and improving referral strategies. This event, the 4th event in the series, will focus on sore throat, cough, cold, and flu management, which are very common minor ailments that we see in pharmacies. Pharmacists hold a vital position in enhancing health and self-care literacy for the management of these minor ailments. Health literacy can help individuals take an active role in managing their colds, sore throat, and flu by understanding how to prevent them, recognizing symptoms, knowing when to seek medical attention, and understanding treatment options. Today's event aims to understand the clinical aspects and health literacy needs with regards to sore throat, cold, and flu, identifying strategies for pharmacists to enable health and self-care literacy in the management of sore throat, cold, and flu, and discuss enablers across education and training, care protocols and services, access to patient information, and referral strategies. We have a very knowledgeable panel of experts today with us. I'd like to thank them personally for the effort, not only to preparing these slides, but also in some cases attending this live webinar in a not very convenient time for them. So thank you very much. It is we have Douglas Bourgoin, who's an adjunct associate professor from the University of Utah College of Pharmacy from the USA. We have John Bell, who's a practitioner and teacher at the University of Technology, Sydney in Australia, and Effie Matsurani, who's a reader in pharmacy practice at the Cardiff University School of Pharmacy in the UK. So it is my pleasure to introduce you first to Douglas Bourgoin, who's PharmD FAMCP. He's an adjunct associate professor at the University of Utah, the College of Pharmacy in Salt Lake City in Utah, in the US. He is also the Chief Strategy Officer for Cooperative Benefits Group, a pharmacy benefit management company, and a founder of Farmer and Chemist, a premier purveyor of quality cannabinoid products. Dr. Bourgoin's pharmacy career spans more than 25 years. He has served as an executive at several healthcare organizations. Doug received his BS and Doctor of Pharmacy degrees from Midwestern University Chicago College of Pharmacy in Downers Grove, Illinois. Dr. Bourgoin is a member of Global Respiratory Infection Partnership and is a board member of the Biologics and Biosimilars Collective Intelligence Consortium. He is also a member of the Academy of Managed Care Pharmacy, where he served 5 years on the board of directors and as the organization's president from 2012 to 2013. Doug is a fellow of the Academy of Managed Care Pharmacy. Doug, thank you so much for being with us today. The floor is yours, please.
Jaime, thank you for that kind introduction, and welcome to everyone. I agree with our introduction that it's a wonderful thing that FIP provides this series on self-care. I think that's fabulous, and is certainly something that we as pharmacists can use in our daily practice, especially for those of you working in a community setting where you have patients coming in every day. Now, think about the last time that you had for yourself a cold, a flu, or a sore throat, or the last patient that came into your pharmacy complaining of one of these three things: sore throat, cold, or flu. As you reflect on that, you think about the misery of that sore throat and trying to get relief. You also probably imagine the people who are coming in asking you for help when they need help so severely as they're trying to relieve their symptoms, and they're just looking for anything that will help them so that they can feel better. Well, today my responsibility is to walk us through the clinical aspects as well as some of the health literacy needs for sore throat, flu, and common cold. And then my colleagues will get more into the details of how we can help our patients and responding to some of the needs that they have. So first, just to level set on the clinical aspects of each of these, and we'll start with the common cold. So the common cold is usually caused by a viral infection. It's generally benign and self-limited, meaning that after 7 to 14 days, most people's symptoms will resolve on their own, which is a beautiful blessing of the human body. However, when we think about the United States as well as throughout the rest of the world, it is the most frequent acute illness that occurs in our population. The average adult has about 2 or 3 colds per year. And the average child, now this is surprising, can have somewhere between 8 to 12. Now, a lot of those colds we know about, and some we don't really know about, meaning our children might just have a runny nose or a little bit of a cough that lasts a day or so. And then the symptoms get worse, or they resolve on their own. Like we said, it's a self-limited disease. When we think about days lost from work, so people who couldn't go to work because they weren't feeling well, about 40% of those missed work days because of illness are due to a common cold. So it's a pretty staggering number in terms of cost to our, to society. In the US alone, if we look back, it's about $17 billion a year with direct costs, and a staggering $22.5 billion a year in indirect cost. So indirect costs, including things like lost work days. As we consider what the clinical features of that common cold, I think we all know them, but let's review. We have rhinitis or runny nose, that thick congestion, sore or dry or scratchy throat, which if you're a presenter, you sometimes get even without a cold. A cough is often associated with common cold, as well as malaise or just fatigue and fever, sneezing, and sometimes we have some nasal discharge. Now, nasal discharge can be a little bit confusing because some folks believe that the darker color or the more thick the mucus and nasal discharge, the more prone someone is to be diagnosed with a bacterial infection. However, studies have shown that that is not generally the case, and color of discharge really doesn't make any difference. So as we start thinking about some of the needs that my colleagues will be addressing more specifically, first, we need to help patients understand the symptoms of a common cold so that they can differentiate for themselves if it's a serious illness or a less serious illness. Also, to understand the difference between cold and flu symptoms, which is tremendously important. And once you know, you know. There is generally a pretty big difference between the cold and the flu for folks who are aware. Identifying when to receive medical attention, including when to come to the pharmacy for self-care, and then knowing how to prevent the spread of illness, which we worry less about today, meaning that after the last 3 years or so, I think we're all very good at limiting the spread of illness and the shedding of these viruses. However, we need to be vigilant and remember the things that we've learned over the last 3 years and not get too casual about them. And then choosing the most appropriate over-the-counter medicines for self-care measures. That's my favorite part. As a pharmacist, we don't often get to give someone who comes into the pharmacy something that can relieve their symptoms almost immediately. For example, a patient comes into the pharmacy and you give them a blood pressure medicine. They're not going to say, "Oh, I feel so much better. Thank you very much." However, when someone has a cold and you can provide them with a recommendation on appropriate self-care measures that are over the counter to relieve those symptoms, then they are grateful, and it's so rewarding. Now, as we shift into the flu, we said, if you know, you know. And for those of us that have had the flu versus just the common cold, we get better at distinguishing the two symptoms and being able to differentiate. However, they do share a lot of symptoms, and so we need to teach people and then, unfortunately, have the experience ourselves. So influenza is generally caused by a viral infection, so we think influenza A, B, or C, depending on the time of year and the flu that's floating around your neighborhood and your community. The Centers for Disease Control estimated that just in this last cold and flu season, we had somewhere between 26 and 54 million cases of the flu in the United States. So that's a pretty big number, from 26 to 54. But think about it even on the low end. If there were 26 million cases of the flu in the US, that's a pretty big number. And so I think, we had very few flu outbreaks during our COVID years because we were staying home, because we were wearing masks, we were washing our hands more frequently, and using hand sanitizer and not shaking hands. But this last season, flu in the United States bounced back really quickly to pre-pandemic levels. It's estimated also that the flu, because of how mean and nasty it can be on the human body, accounts for a fair amount of mortality throughout the world. For folks who are under 65, it's relatively benign. Once we age and get into that 65 to 74 or over 75 years old, we can see that the flu really takes its toll on human mortality. So helping folks to receive self-care is a big portion of what we can do to alleviate symptoms, and then just being aware. Worldwide, there are over 3 to 5 million cases during epidemic years in different locations throughout the world. So these flu symptoms are characterized by, now this is the most important distinction that we need to teach our patients about, and that's the sudden onset. A cold or a sore throat can have a gradual onset, and you feel like it's coming on, but the flu really just packs a punch and hits us right all at once with a lot of symptoms. There's generally a cough associated with the flu. However, that cough is usually dry, so it's not a tremendously mucus-producing cough. We get headache and muscle pain, that severe malaise where we're just not feeling like we can do anything, and we just need to lay on the sofa, and we're not even interested in watching Netflix or some other streaming service because we feel so terrible. And it's often accompanied with sore throat and runny nose as well. So the most important feature that we can remember about the flu is 3 really: sudden onset of fever and headache with that muscle and joint pain frequently associated with cough and sore throat. So what do patients need? Well, I don't want to sound too repetitive. However, and it's not going to surprise you. Your pharmacists, your professionals, you've been treating patients in your stores and clinics for a very long time. But we need to teach patients some simple things, recognize those symptoms, and how to differentiate the difference between a cold and a flu. And as we said, that sudden onset of fever with headache and malaise are really the hallmarks of flu symptoms. Understanding when they need to get help and the importance of early treatment. Now, it really is important, especially for our elderly population, to seek medical care as quickly as those symptoms come on, so that we can do the best to prevent the continuation of the illness and to relieve symptoms. And then remembering those things that we learned from 2020 through 2022. And those are related to hand hygiene and of course, vaccination. We have a wonderful flu shot that we should be getting every year. In my neighborhood, in my neck of the woods in the Western United States, we tell people that we should receive our flu vaccinations sometime September into October, depending on when the flu vaccinations are available. There are some practitioners that even start as early as late August, depending on how the flu is being transmitted in their community. So if you think about it, we want to get the vaccination as early in the beginning of flu season as possible, and then remember all of those things that we can do to prevent the spread of illness and to relieve symptoms for ourselves and for our patients. The last area that we'll talk about, which I think is really one of the most interesting, but from an epidemiological perspective, has some of the least data because it's so common. Think about all the patients that have come into your pharmacy complaining of a sore throat, and how many options we have as pharmacists to provide to them self-care choice so that they can relieve those sore throat symptoms. Well, it's estimated that we have about 82.2 episodes of sore throat per 100 child years. So that's a pretty big number. I think we can all say that we maybe in the last year have experienced some type of sore throat and needed some type of relief. And that sore throat can come even when it's not really caused by an illness. So sore throat can be caused by environmental concerns, where we have dry days and we just can't get enough water to stay hydrated, and so our throat gets sore and scratchy. So the global burden is staggering, as you can imagine. However, we still need some better data for standardized studies for us to evaluate the real impact worldwide. However, we do have some interesting information around why people go to the doctor. During our introduction, it was mentioned that I'm a member of GRIP, or the Global Respiratory Infection Partnership, and I'm so glad to belong to this organization where our goals are to reduce inappropriate use of antibiotics and help people understand how to appropriately care for themselves. GRIP has compiled some information, and one of the questions that we asked people is reasons for visiting doctors. And some of this data has been published by some of our GRIP colleagues. And as you can see here, the fourth item down, they really just want relief. And so we'll talk about some of those options. And then 55% of folks say they really want an antibiotic. Remember, as pharmacists, we need to train our patients that antibiotics don't work for the sore throat or for any viral infection. So what are the clinical features of a sore throat? It's pretty common. We know what they are. Scratchy, pain in the neck, swelling, can be associated with fever or headache. So they share some common symptoms with the flu or with the cold, but it can just be a scratchy sore throat all on its own. What do we need to do from a health literacy perspective? Same things, no surprise. Recognize the symptoms of a sore throat, understand when to receive medical attention, especially from our pharmacists, knowing how to prevent the spread of illness, and then identifying those all important over-the-counter medications for self-care. And that's really where we want people with sore throat to understand that there is relief, and it can be immediate, and it will help them during the duration of their sore throat symptoms. So with that, I will turn the time over to my GRIP colleague, John Bell, and to our organizers. Thank you.
Thank you for the wonderful session. The next speaker for today's session is John Bell. And John Bell is a practitioner, teacher in primary health care and professional services at the Graduate School of Health, University of Technology, Sydney. He is also corporate relations consultant to the Pharmaceutical Society of Australia and principal advisor to PSA's Pharmacy Self-Care Program. John has a community pharmacy practice in the eastern suburbs of Sydney. He is a former national president of the PSA and president of the Australian College of Pharmacy Practice. He was vice president of the FIP from 2006 to 2014. He is currently a member of the Global Pain Faculty and the Global Respiratory Infection Partnership, international multidisciplinary groups established to address respectively the issues of pain management and of antibiotic stewardship. In 2021, John was appointed the inaugural chair of the Australian Self-Care Alliance. Over to you, John.
Thank you very much, Bernardo. It's great to be with you amongst a bevy of exciting presenters on a really important topic, and that's the minor ailments generally, but more particularly, of course, the role that we have as pharmacists in enabling self-care for the treatment, the management really of cough, colds, and sore throat. And the elephant in the room that Doug almost mentioned, that COVID-19, which is not quite completely gone away, but it's still with us. Now, I wanted to come back to self-care and what that's all about. There have been a number of definitions of self-care over the years, and WHO finessed this definition back in 2013 to say that it's the ability of individuals, families, and communities to promote wellness, prevent disease, maintain health, and cope with illness and disability. And this is an important part, with or without the support of a healthcare provider. So people are not expected to do all this on their own, just manage their condition, whatever it is, whether it's an acute illness or a chronic illness, not to manage it on their own, but with the support of a healthcare provider in many, many cases. Now, Bernardo mentioned the Australian Self-Care Alliance, which was established a couple of years ago to promote self-care to government, to healthcare practitioners, to the community. And we use the term to describe both self-care as capability, knowledge, skills, and confidence to effectively engage in self-care, and also self-care activity. So that involves behaviours, day-to-day activities that constitute self-care of individuals. So we see it very much as self-care as shared decision-making with individual efficacy needed to enable self-care, and it refers also to healthcare professionals, consumers working together. We believe that's really, really important. Now, the International Self-Care Foundation established these 7 pillars of self-care. Well, they were the ones who first, I think, put out this concept of 7 pillars. And they're all very relevant to what we're talking about today, tonight, this morning, wherever you are in the world, all very relevant to sore throat, coughs, colds, and flu. So knowledge and health literacy, and I'm going to go in a little bit more about that in a second or two, but also mental well-being, physical activity, healthy eating, risk avoidance, good hygiene, and also the appropriate use of products, of medications. So they all relate to what we're talking about at the moment. Now, knowledge and health literacy is, as you might have noticed, the very first pillar of self-care. It includes the understanding of health and disease, the importance of healthy lifestyles, and the causes of illness. And its most basic, health literacy refers to the ability of a patient to understand information given to them by healthcare professionals. It's important, therefore, that when we're talking to our patients, that we understand that they understand. Often, the information that we get and we deliver is confusing, it's complex, it's often designed for a clinical audience, not a non-clinical audience like most of our patients will be. So they might be intellectually astute, but they might not have health literacy, and that's what we need to be aware of. That's our role. Getting back to sore throat, and sore throat is usually the precursor, I think kind of Doug alluded to this, of coughs and colds and the flu. Most sore throats are caused by viruses. Doug mentioned that. Most of them, in fact, 85–90% of sore throats are caused by viruses, mostly rhinoviruses, then coronaviruses, of which, of course, COVID-19 is one, influenza, parainfluenza, respiratory syncytial viruses, adenoviruses, and there's quite a few we just haven't worked out about yet. But then there's the bacterial infections that cause sore throat, bacterial pharyngitis. It's Streptococcus pyogenes that's the chief culprit here. It causes maybe up to 15% of sore throat in adults, but even more so in children between 5 and 15. So we need to be aware of the risk factors for that age group particularly, and if necessary, refer to the GP, because it's that in that age group that maybe antibiotics might be necessary. Having said that, these guidelines that I've put on the screen here come from the therapeutic guidelines in Australia. However, they reflect guidelines all around the world. In other words, do not prescribe, do not give antibiotics for viral pharyngitis and tonsillitis. For patients who are not at high risk of acute rheumatic fever, and that's very, very few people indeed who are at risk, then we use symptomatic therapy, the kind of therapy that we in community pharmacy can provide, depending on the most troublesome symptoms. If it's a sore throat, it's usually an anti-inflammatory or an analgesic. If it's a cough, it might be a decongestant or a cough suppressant. If it's nasal inflammation or congestion, it might be a decongestant. It might be an anticholinergic if it's rhinitis, and so on. Now, streptococcal pharyngitis and tonsillitis, that's the maybe 5 up to maximum 15% of sore throats which are streptococcal. Even there, the durations don't last all that long, maybe up to 7 days. As Doug put it, they're self-limited or self-limiting infections. There's no improvement between patients treated with or without antibiotics. So always weigh up the benefits of antibiotics, and in this case, there are very, very few benefits against the harms that may occur, and sometimes those harms can be considerable. What do patients think about this? They expect 1 in 5 expect antibiotics for cough and cold. We will see it there. Someone's talking over me. I think it's me talking over me. So I'll move on to the next slide here. Patients want antibiotics because they think they can recover faster from colds and flu. They think that antibiotics nip colds in the blood as well maybe, and reduce the risk of serious illness. They think it prevents them getting the flu. They think that there's a cure for bacterial infection if they've got green or yellow mucus discharge. Now, that's not the case. Coloured or thick discharge, as Doug kind of mentioned as well, it's only an indication that the immune system is working and it's working well. It does not indicate a bacterial infection. They believe that maybe antibiotics are cost effective, that they can go back to school or work sooner. On the other hand, they think it's inconvenient to see the doctor, and that bacteria, or rather antibiotics, some people now realise kill good and bad bacteria and may lead to resistance. So GRIP, that Doug's already mentioned, the Global Respiratory Infection Partnership, conducted a study, and I'll just go through this quickly. I don't expect you to read all this because it's a little bit confusing even for me, and I've been over it 100 times. We established this, I think it's called a social media listening kind of survey, and we looked at various attitudes around the world of people using social media. We found that Twitter was the most common source of conversation about sore throat. You might be able to read a little bit of there. It was the dominant source of conversation in social media, particularly from parents talking about their children, what they described. It was also Twitter the source of some health authorities giving vent to their information and advice. Sufferers during the last few years, of course, were worried that sore throat might be an indication of COVID-19, but there are all kinds of other social media platforms that people were involved in and were getting information out. Much of it, quite a lot of it, misinformation. So if we're going to meet that challenge, that line I've got down the bottom there, we need to know the platforms. We need to prioritise our communication through maybe Twitter, Facebook, and the other discussion forums, as well as face-to-face with our patients. So I mentioned that Twitter was the most prevalent social media platform. We're able to divide the various discussions into 5 groups. We saw there were peer educators. These were people who felt it was their duty to educate their friends and family and their acquaintances about the importance of following antibiotic prescriptions thoroughly to mitigate against antibiotic resistance. There were the antibiotic cautious consumers, and you can see them there. They believed that antibiotics were unnecessary for sore throat. Good for them. They were driven by their explicit awareness of antimicrobial resistance, or perhaps a reluctance to take what they thought was hard, strong medication. Then there were the non-scientific antibiotic opponents. They thought they should never use antibiotics. They were reluctant toward taking medication anyway. Their preference was for natural, so-called natural holistic treatment, or they were conspiracy theorists as well about antibiotics. Then there were the determined pro-antibiotic consumers. These were people, they were convinced that in any event, a sore throat always warrants an antibiotic. And then there were the believers that thought, well, they made a distinction that antibiotics may be useful and that they would advocate them because they felt they were always going to be better than a non-antibiotic. So the message here, if you're going to involve your patients and enable them to be good self-carers, tailor your message. Tailor your message in consideration of the group that you believe your patient falls into amongst these various groups here. These were some of the I guess the misinformation that we found people were coming up with, the misconceptions. We need to debunk these myths if we're going to enable people to self-care and to have good health literacy. Some people thought antibiotics were strong medications, which are always more effective at treating sore throat, regardless of whether it's bacterial or viral. They thought antibiotics would help them get better quickly. They thought they might catch antimicrobial resistance like they catch an infection if they take too many antibiotics. They thought that they themselves became resistant rather than it's the bacteria that become resistant. So a number of issues we actually need to address. How do we do that? This is the crux of my message in any event. Know your patient, know your consumer, know your customer. Spend some time understanding where they come from. Ask them questions, things like, when did this infection occur? When did the symptoms start? How long have they occurred? What are the symptoms? What are the most troublesome symptoms? Tailor your message, if you can, to one or other or more, if necessary, of those 5 distinct groups I've mentioned. Address the misconceptions and debunk the myths. Know the social media platforms and prioritise your communication to them. We as pharmacists, individual practitioners in the community and our own organisations, our national organisations and our international organisations like FIP, should be communicating more and more through social media. Empower your community to understand the very best messages that we can provide. Now, Doug mentioned GRIP. I'm going to mention it again. There's some great resources. The website's there, gripinitiative.org, grip-initiative.org, a number of resources that you can use to help you explain the very best information to enable self-care and improve health literacy to your patients. Thank you very much indeed. I'm sure there'll be some questions later. I hope so.
Yeah, we are already having some questions through the Q&A place in the Zoom tool. Thank you so much, John, for an excellent presentation. We'll wait for the questions until the end of the session. Thank you very much. So it is my pleasure now to introduce you to Dr. Mansurani. She joined the School of Pharmacy in 2011 as a lecturer, following an MCC, and a PhD in medicinal chemistry, succeeded by a career in community pharmacy. She is passionate about empowering the next generation of pharmacists to provide a holistic healthcare approach. Her position as research lead for Choose Pharmacy in Digital Health and Care, Welsh and mixed clinical and scientific background help her understand the challenges surrounding digital health, which is very important nowadays, of course, clinical and professional practice and informs her teaching and scholarly activity. She has developed an expertise in developing, implementing, and evaluating pharmacy services. Her scholarly activities have provided an evidence base to the Welsh government for commissioning of pharmacy services, which have transformed professional practice. I'm very supportive of these services being provided by pharmacists in Wales, also in Scotland. The increasing UK use of point-of-care testing in antimicrobial stewardship and the introduction of a community pharmacy discharge medicine service in England are just some examples of this impact in areas of significant importance to policymakers. However, Dr. Mansurani has not been able to join us live today, but she has been very kind to send us a recording, which we will play now for you.
Welcome everyone to this FIP event, and thank you to the organisers for the opportunity to share some of our work. I will talk to you today about an example of how patient education can be promoted in community pharmacies in terms of managing uncomplicating symptoms of a minor ailment, sore throat, with a case from within the United Kingdom. And when I say from within the UK, I mean from Wales, which is this little part of the map here. Health is one of the devolved powers in the UK, which means that in Wales we have our own health minister and we have control over what is happening in the health system. In Wales, there has been a wider government policy to shift the management of many common ailments either to self-care or to professionals other than GPs. One such strategy has been to better utilise the skills of community pharmacists in managing acute minor ailments. So about 10 years ago, the local government started funding the Common Ailment Scheme. Under this scheme, patients with any of a list of 26 different common ailments can get assessed in their community pharmacy and, if appropriate, receive treatment free of charge. Sore throat has been one of these common ailments from the start, but under the scheme, no antibiotics could be supplied. So when a pharmacist thought that a patient would benefit from an antibiotic, they had to refer them to a GP. Unfortunately, that meant that many patients preferred to go and see a GP directly, as they didn't appreciate how much a pharmacist can help them. And of course, it's very difficult to differentiate between a viral and a bacterial infection. For this reason, a national sore throat test and treat service was commissioned in 2018, initially as a pilot in 56 pharmacies only in 2 areas of Wales. The service adopted a staged test and treat service strategy for all patients aged 6 years and over presenting with acute sore throat at a participating pharmacy. And community pharmacies really had a pivotal role to play in triaging patients with this strategy. A pharmacist is initially screening patients to ensure that there are no red flags that would mean an immediate referral to a general practitioner or emergency services as needed. After that, the whole service is based on trying to differentiate a viral or bacterial etiology of a sore throat. There is another clinical assessment using either fever pain or centre clinical scoring. These validated tools ask targeted questions about symptoms that are distinct between 2 etiologies. Each of the criteria score 1 point. The higher the score, the higher the likelihood of streptococcal cause, so presence of bacteria. Patients who meet threshold scores based on national guidance, and that is fever pain 2 and above or centre 3 and above, are then offered a point-of-care test in the pharmacy, allowing pharmacists to quickly check if Streptococcus A is present. This first step of clinical scoring allows targeted testing of those patients most likely to have a strep A infection, rather than people who are carriers of the bacteria normally without any symptoms. Patients who don't meet threshold scores for point-of-care tests receive self-care, which is essentially what would normally be offered under the traditional common ailment scheme. Important to note as well that only evidence-based symptomatic treatment is considered, and that is paracetamol or ibuprofen. The point-of-care test is conducted in the pharmacy in a private consultation room by the pharmacists. And what happens next really exemplifies the role that the pharmacist can play with patient education. As we know, the evidence is that even bacterial strep A infections are self-limiting and tend to go away in 3 to 5 days. So when the point-of-care test result is positive, patients don't have to take antibiotics, even though they meet the criteria to do so. They make a joint decision with the pharmacist after they discuss risks versus benefits. If they decide they want to take antibiotics, a supply is provided in the pharmacy without the need to go to the GP. When the point-of-care test result is negative, no antibiotics are offered. The evidence is explained again and self-care is discussed. You can see here the service's aims, all arising from the goal of safe transfer of care of uncomplicated sore throats to community pharmacy. We will fourth goal of improving antimicrobial stewardship by educating patients so that they understand the difference between viral and bacterial infections, the self-limiting nature of the latter, and the limited role of antibiotics. To understand what patients thought of the service and the education that was provided with it, and whether we have achieved the same really, we undertook a large study at the start of the service, using surveys that were provided to all patients who have had a consultation with a pharmacist about a sore throat. This is the survey that we used, and we gave it to everybody, regardless of whether they had a supply of antibiotics or not. We managed to engage more than 500 patients in this evaluation. Pretty much everyone was satisfied with the service itself, the way it was delivered by the pharmacist, and the increased options for consulting with a healthcare professional it offered. The word cloud here has been put together using all the free text responses that the patients left in the survey. And I have included also some direct quotes from patients, just to showcase a bit more the high levels of satisfaction. So how about patient education? Is that working? I have highlighted this item here as it captures an overall attitude of patients, and it shows that more than 96% of them felt more confident about managing their condition after the service and after the discussion with the pharmacist. What's the impact of that increased confidence? To start with, we had about 40 patients that, even though they met all the criteria for receiving a supply of antibiotics, decided to self-care after discussions with the pharmacist. In addition, in our population of patients, which is highly representative of the total population of patients who had a consultation with a pharmacist, 2/3 try to see a GP before attending an STTT consultation. This decision to access a GP as a priority seems to be changing, with all but 6 patients reporting that they will return to the pharmacy next time they have symptoms of sore throat. So, what is the outcome? We can see that there is a high satisfaction with the service, and the service contributes to patients feeling more confident to self-care, and the service also may have a role in promoting antibiotic stewardship. And that's all down to patient education and the role that community pharmacists can play in supporting patients to self-care for minor ailments. Thank you.
Okay, it was a great recording. So we'd like to call our speakers and co-chair to open their cameras for the Q&A time. Thank you for you submitting your questions. We already have a few of them, and we will go through most of them since we have a lot of time, which is not common in webinars. So thank you to our speakers to stick into their time. It's been great. So I will go first, asking a question, and I allow myself to select a question that has been already answered live in the chat by John. But it's so common that patients come to us in pharmacies, at least in Spain. Maybe it's not happening in other places, but in Spain, it's super common that they come to us saying, hey, this nasal discharge is green. I think I need an antibiotic. Or maybe they refer to the viscosity as they think that they can kind of diagnose by the way that nasal discharge looks like. Can you please provide us with your thoughts, both Doug and John, if you're so kind, please? First, John, if that's okay.
Yeah, sure. Thanks. I think I did cover it a little, and I think Doug did as well to an extent. It is a very common misconception that if the mucus from the nose is yellow or green, we call it Australian mucus, you know, the green and yellow of the Australian football teams. But people think, yes, if it's nice and thick and coloured, it's got to be bacterial. And that's just so wrong. It's just our immune system working overtime, working well. It's full of leukocytes, that substance, and it's no indication whether it's viral or bacterial. The most likely cause is a viral infection. 85–90% of the cases, they're viral, and most of the bacterial infections, as Effie said in her presentation as well, are self-limited also. They don't need antibiotics.
John, I think you covered it. Beautiful.
Thanks, Doug.
Okay, so Bidata, if you're so kind of asking a second question, please.
Yes, we have a question in the Q&A box, and the question is, why do we continue to call it cold and flu? They are very different conditions, and it is unlikely a flu sufferer would be out visiting a community pharmacy. So this is the question.
Yeah, it's a great question, and it can be confusing, especially because people who don't know the difference between a cold and flu just simply refer to the season as cold and flu season. And the symptoms get mixed up as well, even though they share some commonality. The reason that we call it that, I believe, is just that we get both during the same time of year. And it can be difficult to differentiate between the cold and flu if we forget that the flu is most frequently characterized by sudden onset of fever, headache, and malaise. But they occur during the same time of the year, when in the colder months usually, and that's why we generally say cold and flu season.
I think very occasionally we get people stumbling into the pharmacy with upper respiratory tract infections so severe that it is obviously the flu. And in many countries now, not in Australia, unfortunately, but I know in New Zealand, we can provide from the pharmacy antivirals for the flu. So in that case, we can make an assessment as pharmacists. The question is right and correct in saying that most people who come into the pharmacy and say, I've got the flu, they have a cold. It might be a very severe cold, but we certainly are in a position to differentiate and provide the most appropriate advice.
Thank you. We have, please keep your questions coming. They're very interesting. I will pick this one from Muhammad Ali. His question is, what are the immediate red flags to refer a patient for medical care or a GP? What would you say are the most important ones?
Yeah, I'll take a shot at it, John, and then jump in. One of the first things is a fever for an adult over 103, and for a child. Once we hit that 103 degrees Fahrenheit, John, you'll have to tell us what that is in Celsius.
Yeah, it's about 39.8. You're right, Doug. Yeah, a mild fever, mild increase in temperature, not a problem. So that's the cutoff. Yeah.
Yeah, so I think that's number one.
Yeah, go ahead, Doug.
Second thing is if you look in the throat and see that the tonsils are inflamed and red, or you have pustules, that's also an indication that it's time to see a doctor. And then for really severe symptoms that are lasting more than 10 days, then it's time to see a doctor as well. John, what else would you add or comment?
Yeah, I think, Doug, you're right. I mean, if with symptomatic treatment, which most often is going to be your first choice, there is no improvement after a week or 10 days, then time to see the doctor. The other things I'd mention would be great difficulty in swallowing, dysphagia would be a sign, difficulty in breathing, a wheeze, which could be maybe an indication of a lower respiratory tract infection like asthma or bronchitis. So these are the things where there are at least orange flags and heading towards red flags. And if you're in doubt, will you refer? But be confident, be aware of what the red flags will be. Can I refer you back to that GRIP website, grip-initiative.org, because you'll get lots of information there about the red flags. And one of the things we need to provide our patients with is realistic expectations as to how long their infection is going to last. We talked about 5 to 7 days. That's what we should expect with or without treatment. An upper respiratory tract infection, a viral infection like colds or flu, or indeed most bacterial infections, upper respiratory tract infections will last. Antibiotics won't reduce the severity or the duration to any extent, to any large extent. So realistic expectations about the duration of a sore throat, a cough, aches and pains, earache, and so on. So they will feel more reassured and enabled to self-care with our assistance.
Thank you for the explanation. There is another question from Ritika, and the question is, which vaccine is best to prevent flu? Anyone would like to answer the question?
Which vaccine?
Is best to prevent flu.
In the United States, quadrivalent vaccine is the gold standard, and it is really the only one available. So it generally includes 2 strains of influenza A and 2 strains of influenza B, and that's what we recommend for our patients for flu vaccination.
Yes, we do too in Australia, and I'm sure we're all aware that each year there's a variation, almost always every year a variation with the formulation according to what strains of influenza virus are travelling around the world at the time. Doug mentioned, I think, maybe in August, but certainly in September in the Northern Hemisphere. April, May, so now in the Southern Hemisphere is the time for us to get vaccinated against the flu. And of course, at the moment, and I expect this is probably just about everywhere, we can get the flu vaccine and COVID-19 vaccine together, same day, different arms, same day.
Yeah, and I believe that the strains that we use come from Australia at the beginning of the season. Is that correct? I think so.
Yeah, well, it depends where in the world you are at any particular time, but I think you base your vaccine, Jaime, on what we're getting now, and we base ours on what you'll have later in the year.
Okay. I didn't know that about the second part. Okay, thank you. So I'll pick up a question from Vivienne Watson. I'm sometimes not too confident when we provide our patients or when advising patients about multi-ingredient preps to treat cold and flu, which in many places are available from shelf in gas stations. In Spain, for your information, those medicines can only be dispensed through a pharmacist in a pharmacy, which I definitely think that adds a layer of safety for patients. But sometimes these preparations have, I would say, sometimes a risky mix of medicines, which are not appropriate for everyone, of course. So what do you think about that?
Yeah, I agree that
first, Doug.
yeah, it's tricky, and I appreciate, Jaime, that those preparations are available only from a pharmacist in Spain. That would be very nice. In the United States, you can walk into Costco and buy a bottle of 500 ibuprofen for about $9. Now that's obviously not the same thing, but the availability is literally everywhere. Products with multiple medications that treat multiple symptoms are tremendously confusing. What I like to recommend to my patients is to ask their pharmacist what's going to treat their primary symptom the best, and then select a medication that really treats that symptom. We have the same problem in sleep that we have in cold and in flu and sore throat. And that is, on the sleep side, people sometimes use acetaminophen or paracetamol plus diphenhydramine and to get to sleep. And they really just need the diphenhydramine for sleep. So focus on the one medication that's going to treat the primary symptoms that someone is complaining about is the best thing that I think we can do. And John, what else should patients do, and how else should pharmacists teach us?
Yeah, I think you're absolutely right, Doug. I mean, what we should be doing is identifying with the patient their most troublesome symptoms and treating those, and explaining to people why we're doing that. For most people with a sore throat, an anti-inflammatory lozenge or spray will be the first choice, with maybe flurbiprofen or benzidamine, something similar to that. Maybe an analgesic. It could be ibuprofen or paracetamol as well, if their aches and pains are causing problems too. Occasionally, the multi-ingredient medications are fine, but I think, Jaime, I echo what I think are your thoughts about that. It's not appropriate for them to be sold at gas stations or news agents or supermarkets where there's no advice. Sometimes people take these multi-ingredient formulations, and they're also doubling up on similar ingredients taken from the doctor or from the pharmacy or elsewhere. So it's not ideal. I think we need to advocate as much as we possibly can that people need the very best possible advice about all medications, and they go to the pharmacy for that particular advice.
John, I wanted to add something. I think it's really important, that something that you mentioned, and that is patients doubling up on medications. They don't often realize if they take one medication to relieve some symptoms, and then they take another one, or they get some from a friend, the cumulative dose of paracetamol or acetaminophen can be rather significant. And so we really want to be careful about that. The second thing that we should be careful about when we're talking to patients, or that we should make patients aware of when they're self-treating is the effect of drowsiness, especially when they're using multiple medications and combining different products. We don't generally think about drowsiness when we are using one of those multi-product medications, but a lot have antihistamines in them. And then when you double up 2 antihistamines, you might be very wiped out, which might be a patient's goal sometimes so that they can get some sleep, but it's not ideal and not what we should be recommending as pharmacists that they do.
Yeah, good advice, Doug.
Thank you for the explanation. There is another question from Peter. The question is, how do you distinguish early onset of tonsillitis and sore throat?
Man, that's a really great question. Well, the hallmark symptoms of tonsillitis are the red, swollen tonsils, the epiglottis. If you look in the back and you have, and it's very, very red, very swollen, or if you have pussy exudates, so you've got pustules that are white, then that's the first indication. Second is when you go to the doctor, they can tell pretty quickly if it's tonsillitis or if it's not.
If even though it might be tonsillitis, I mean, the name really indicates the problem. It's inflamed tonsils. Now, whether that's bacterial or viral, unless those red flag symptoms are seen, we can still treat those symptoms of tonsillitis symptomatically. So we shouldn't be afraid of tonsillitis, but if along with the inflamed tonsils, there's extreme difficulty in swallowing or difficulty in breathing as well, then that's when we should be referring.
Yeah, great points, John.
Okay, thank you so much. I'll go for, I'm very much, I'm the technology advisory group of FIP coaches, so I'm very much focused in technology. And since we're talking about health literacy, we have a very interesting question from Justin Wu. First, he thanks you for your excellent presentations, and I need to echo that, of course. His question is about ChatGPT, about use on self-care literacy. How can AI support patients for self-assessment and pharmacists for consultation in cold, sore, cold, and flu? And I will add a little bit into that, saying what is the pharmacy profession going to do with these artificial intelligence tools that make our service in, I would say, low value areas redundant? If you can give a comment, I'd love to hear it.
John, would you like to start this one?
Not particularly. I think Jaime should answer that himself by the sound of it. Look, certainly our organisations need to give a lead here. I don't think we'll ever be out of a job. I don't think AI is going to take over our role. I think, on the contrary, I think we may find it complements what we do, and we may find that we actually are given more resources through AI to be better equipped to advise. I don't see it as a threat to what we're doing, and I don't really see that it's going to take over the low-level consultations either, Jaime, but Doug, you might think differently.
No, actually, I agree 100%. I have to say, though, I love ChatGPT. It is so convenient. So disclosure. I've even paid for the GPT-4 version, so I can have better information. And there is a pretty big difference. And in full disclosure, again, I used it to check the information that I had in this presentation as just a backup. So I think appropriate use of ChatGPT is something that all professions are concerned about, I know our physician colleagues and other prescribers are thinking the same things. And especially when we read news articles that tell us that ChatGPT was better than a physician at diagnosing illness. Now that is a little alarming. I'm more worried about some of our physician colleagues than I am for us as pharmacists, because people are still going to need to come in now that they know that the computer has diagnosed their problem. The computer might also tell them what they need to treat those symptoms, but they're still going to come into us. And so we have an excellent opportunity to talk about the pros, the good things, and the cons or the bad things about diagnosis via ChatGPT.
Yeah, I think that's right. I mean, I think some years ago, when the internet became more ubiquitous, people were worried about what that would bring. And but we know indeed that if we use the web effectively, appropriately, and look for the evidence base, it's of great benefit to us as a resource. I think the same will occur here too.
Yeah, well, people didn't come here to listen to me, but I slightly disagree. And I think that the article that you were referring to, Doug, is something I read the other day. The title is ChatGPT Beats Doctors in Compassion, which was very surprising, and quality of advice to patients, according to one article that was published very recently. So yeah, we need to use it on our behalf and in behalf of patients. That's all I'll say.
I mean, just as well that we are so much more compassionate than general practitioners.
That's true. We are the champions of compassion, accessibility. Yeah, that's true. We need to use those human skills, not only to use them on our benefit as a profession, which we should, but also to develop on them, build on them to improve the service that we provide to patients who really trust us. That's all I'll say. I'll stop talking. So Vidata, please.
But I think, Jaime, it's really important for us to take the opportunity to teach patients about the shortcomings of programs like ChatGPT, and then remind them that not only that we're there, but we've been trained to answer those questions. And so while we're compassionate towards them, while we're showing empathy for their symptoms, and we're making recommendations to them on what they can do to relieve their symptoms, the last thing I think we can do is remind them that the ChatGPT is based on the information that the patient puts in and doesn't have the ability to think outside the box to what might else be going on, or to ask additional questions. So we might say, oh, if you type in what are the symptoms of the flu, then ChatGPT is going to respond with that, but it doesn't know if you really have the flu. So speaking with a pharmacist, we can ask additional questions to narrow down the problem to what's really causing the concern, and be able to provide a recommendation to the patient, whether that's self-care and self-treatment, or if it's referral to a GP.
Yeah, totally. So the last thing I will say, I was texting this morning with a friend, a very good friend from Australia, and I shared with her a figure from an article from United Nations, and it was a decision tree about when was it safe to use ChatGPT, and the question was, does it matter if the output is true? If the answer is no, then it's safe to use ChatGPT. If the output matters, then you should still be a little bit cautious. And I'll finish talking. I'm really short. Sorry.
I like that.
I think it's a never-ending topic. We can have a separate webinar, I think, on this.
Truly.
So we are getting a lot of questions. So the next question is, should pharmacists recommend alternative treatment instead of medicine? What are the natural remedies of cold? So the question.
I'll answer that in a very brief way. Vidata, I would say we should only ever recommend evidence-based therapy wherever it is, whatever it is. We should be recommending something that's evidence-based.
I think that's true, John. Some of the alternatives that we have a lot of patients using are echinacea. They might be using some kind of turmeric. But I think in my experience, the best non-medication symptom reliever for a lot of these symptoms is a simple nasal wash with saline. Whether using a spray or a pot or even steam seems to relieve the symptoms better than many alternative medications and even some medications, because we get confused and we think we need the cold, the flu, the sleep, the achy fever, stuffy head, so I can rest medicine. And what we really need is just a steam shower or a nasal wash with saline, not with water, but with saline. And that relieves so many of the symptoms, and it's probably the best alternative medicine.
I think that's really good advice, Doug. I think I noticed very early on in the chat or in the questions that someone had a question about sinus problems, and we always recommend a nasal wash for sinus or allergic rhinitis and for colds and flu. I think it's really, really good, and it complements whatever other pharmacotherapy you're recommending.
Thank you. There were some materials done by FIP. I worked on that. I've tried to find the reference or at least the link and put it in the chat about what you said about non-medicine improvement of this minor ailment. So I'll try to find it. We have a couple of questions related to sinus problems that are sometimes related to cold and flu, and using antihistamines. Can you please comment on that, please?
Well, if the sinus problems, sinusitis is inflammation of the sinuses. If it is sinusitis, if it's an allergic cause, then antihistamines could well be effective. If it's an infective sinusitis, then you may need antibiotics. In any event, quite often an anti-inflammatory, like an intranasal corticosteroid spray, may be helpful as well. It's all about managing those symptoms. As I just mentioned, for sinus problems, and particularly as a result of, say, allergic rhinitis, my go-to therapies are usually a nasal wash, sometimes a decongestant, and in any event, an intranasal corticosteroid. So it's a multi-pronged attack, and it depends a little bit on the severity of the symptoms. Initially, just the saline wash that Doug mentioned, it could be sufficient. The decongestant is really only for very short-term therapy to open up those nasal airways, and the intranasal corticosteroid therapy might be continued for a week, several weeks, or much longer than that, depending on the actual cause and the results you're getting.
Yeah, I like the use of everything that John said. I like the nasal steroids. Decongestants are also helpful. Of course, cough suppressants or cough medication that can loosen some of the phlegm is a nice way to get some symptom relief. However, antihistamines, there's a question about that. Antihistamines in some of the cough and cold preparations, for the most part, while they're drying, are also there for sleep and for helping someone to try to rest better at night. And the concern that I have is what we said before, someone who's taking multiple products or taking a little bit too much, getting too much antihistamine. How many times has a patient come in and said to you, well, if a little is good, a lot must be better. And that is not the case with cough, cold, or other types of treatments, especially those that include antihistamines.
Yeah, we need to differentiate too between the non-sedating antihistamines and the older sedating antihistamines, most of which are still used in cough cold preparations. So the non-sedating antihistamines will be good for allergic rhinitis. They won't be good for cough cold because they don't have an anticholinergic effect, which the older antihistamines do, and which enables them to have that drying and sometimes mild cough suppressant effect. But they're the ones, as Doug mentioned, we need to be very careful with.
Thank you for the explanation. There is another question which is related to, I think, ADR. The question is, we should also keep in mind that some medicines, example, carbimazole, should the patient be taking it, can cause sore throat due to agranulocytosis. So I think it's about ADR. So what about the ADR? Since I work in pharmacovigilance, I'm also concerned. What about the ADR of the drugs which are used in the treatment?
Well, that's a really great.
You go ahead, Doug.
Yeah, thanks. It's a great comment, and something that we definitely need to be aware of. Which I come back to ChatGPT. If someone puts in, I have this sore throat, and they don't mention that they're taking a medication that may cause a sore throat or have this problem, then they're going to go off in the wrong path. So coming in, speaking with the pharmacist. So I think something that we need to be reminding ourselves of is that if that patient is your patient and you're filling their medications, to be aware of medications that they're using so that you can advise them that, and as in this case, the medication that they're using is causing their sore throat or may be contributing to it. However, they can continue to use symptom relief even for that type of sore throat, whether it's a lozenge or a spray to help relieve some of that dry, scratchy pain. That's totally appropriate.
Yeah, I agree, absolutely. We should always be asking our patients when they come to get non-prescription therapies from us, what other medications are you taking? What other medical conditions do you have? Before we're recommending something. But in any event, as Doug has said, symptomatic treatments will still be helpful for these people.
One last question, maybe a very brief comment. I like that very much. It's not directly related to our topic today, but I think it's very important for pharmacists, including me in this webinar. How can we change the perspective of both patients and physicians regarding to pharmacy when they see us only as medicine sellers? How to build the trust within the community when some people view our profession, as I said, as just selling medication? This question comes from Selma Castell. Thank you very much.
Wow, that is one of the biggest problems that we face, I think, worldwide. Unfortunately, we go to pharmacy school, we become excellent practitioners in understanding disease. We have a lot of patients that come to us as their primary care provider because of what you said, Jaime. We're so accessible, and yet they still view us as pill pushers or someone who's just trying to sell them something. I think one of the best ways that we can change that attitude is to do some of the things that John has been talking about today, and that's establish a relationship with the patient and then ask them questions. Even if they're not our regular patients and they're just someone who we've never met coming in seeking advice on relief, if we take some time, show some empathy, ask questions, and and then help them understand the disease process or what's going on within their bodies, then we've changed their attitude. We've become a friend and a partner that they can rely on, and we've taught them something. So now we're educators. Once we become an educator to the patient, then they're willing to listen to us about self-care treatment or referral or no treatment at all. And they walk away feeling like they actually spoke to a healthcare provider, which I think is one of the frustrations with general practitioners. They're so squeezed for time that they don't get enough time for education. They just get a response. So I think one of the best ways for us to change that attitude is to take time, talk with the patient, teach them something, and then make a recommendation. And I think attitudes will change.
Yeah, I'd absolutely agree with everything you've said, Doug. I think that's so correct. Interestingly, you know, through the worst of the COVID-19 pandemic here in Australia, and I think in some other parts of the world as well, many doctors' surgeries were closed, or you could only contact them by Zoom or by the phone called telehealth, and yet all pharmacies stayed open, many of them extended hours, and people became to learn that we were more than just the provider of product, that we were actually there to help them with their health care and to enable self-care and to improve their health literacy as well, which is what this webinar has been about. I mean, if COVID did anything good in our profession, certainly in my country, it put pharmacy on the map. We did more vaccinations for COVID and the flu in the last few years than we've ever done. And we became established as the place where everyone in the community went for their flu vaccine and their COVID vaccine, not their doctor, but to their pharmacy. So that's given us a bit of an edge in expanding and broadening our scope of practice. And I think that indeed is what FIP is encouraging as well. It's going to be different in different countries from time to time, but by and large, around the world, with support of organisations like FIP, particularly FIP, we're in a great position to broaden our scope of practice. And with that will come an acknowledgement of what we actually do.
So I think with this, we come to the end of the Q&A session. Thank you for such a wonderful session.
Thank you.
The remaining of the questions, I don't know whether it will be answered with email or what will we do? Remaining of the unanswered questions.
I'll check the questions that remain unanswered, and I think we think that they are important enough to go again to our guest speakers today and abuse of their time and expertise. We'll circulate them later with their answers. But I think it's been a very long and comprehensive Q&A. So we'll check. Thank you, Vidata.
Thank you so much. Thanks for the opportunity.
So we can have these slides, please, back. Thank you.
So I would like to take this opportunity to also tell about the upcoming webinar, which is on 30th May 2023. And the webinar is about the heartburn and indigestion. So please register for the webinar, and it will be one of the most interesting sessions in the coming days.
And we have our next FIP conference in beautiful Brisbane, very close to John. So FIP conferences are an excellent opportunity to engage and interact with pharmacy leaders worldwide and to learn about pharmacy. And a very much different practitioner after attending FIP conference, I must say. And registration and abstract submission for FIP's 81st World Congress in Brisbane, Australia is now open. Submit your abstract. The deadline is already finished, and register before 15 June for the special early bird fee. You can find more information about the Congress on the website brisbane2023.fip.org.
So this information is about the journal, Pharmacy Education Journal, PEJ, which is a fully open access peer-reviewed journal that has been serving the domain of pharmacy education, workforce development, and associated fields for over 20 years. PEJ specifically supports and encourages early career academics, scientists, and practitioners to publish work with a no-cost route to dissemination, particularly where scientific English is not a first language.
And lastly, I would like to encourage you to check all the future FIP digital events here at events.fip.org. And this is all from us today. It was a very interesting webinar. As always, I personally learned a few things to improve my practice. I would finish by thanking you for attending this event when we are so busy in our pharmacies, and especially, of course, to our guest speakers, John, Doug, and Effie. Thank you so much. I must say that I enjoyed it a lot. Thank you for being with us today. Bye-bye.